Good morning, everyone. Again, sir, as Tathagata Chatterjee sir has kindly agreed to give us some more feast about morphological co-founders of hairy cell leukemia. So, hematology, sir is one of the masters, and we'll be very happy to hear from him. Sir, over to you.
Good morning, ladies and gentlemen, and good morning, Professor Nechudi. Yesterday we talked of mimickers of Hodgkin's lymphoma. Today we will be talking of something in the chronic lymphoproliferative disorders. And when we talk of chronic lymphoproliferative disorders, we frequently come across the cells with profound hirsutism. That is the hairy cells. Okay. So not all hairy cells are hairy cell leukemia, and not all hairy cell leukemias are hairy cells. So you have to understand that. So cells with cytoplasmic projections or hair-like projections are not necessarily hairy cell leukemia. And many hairy cell leukemias may not show you the cytoplasmic projections. So if you have understood this small statement, which I have simplified, then we will proceed to the lecture, right? So when I was in Tata training under Dr. Anita Borges and Dr. Roshni Chenoy and Dr. Krishnamurthy and those famous ladies and Dr. Chitralekha Soman. Now, Chitralekha Soman was actually the HOD of Tata Memorial Hospital, Bombay. And she was the lymphoma person. And she had trained those days in Kiel. You see Kiel's classification? So she had trained in Kiel in Germany. And she used to talk about the centrocytes and the centroblasts. The names are very fantastic and quite confusing to all of us. And lymphoma was made to look so difficult to diagnose. So that's why we used to coin some poetries. Like this poetries, we all know lymphoma, they have T cells or B, IgM, IgA or G, centrocytic, centroplastic, names quite fantastic, like KI1 or AILD. So they had this particular Roshni Chenoy when she used to take breast pathology. She used to start her lecture with small poetries, and she used to make it herself. Now this poetry is not mine, it is copied. Okay. So I've copied it from a book, and I'll tell you about the book later on. Chronic lymphatics the best. We all know, agar madna hai to CLL se mado. Chronic lymphatics the best, grow slowly than all of the rest, may go on for years with minimal fears, and its cells feed the host like they are guests. So when you read this poetry, you realize that CLL is quite indolent compared to the aggressive ones. So idea is nothing else. Idea is to, you later on you all will become teachers. So when you teach the subject to your students, you can start with an anecdote. You can start with a personal experience. I got so much of personal experience. I can really go on and on. So if you make that class interactive, you see, if you make the class, relevant, your poetry should be relevant to your class. You cannot talk about Shakespeare and then talk about lymphoma. No, you have a poetry which is relevant to your class. So like that, I advise you to go on in class and please read history of medicine. For example, you're reading Hodgkin's lymphoma, you have got no idea of Thomas Hodgkin's. It is a disgrace. There's so much of history waiting for you to explore. So with this in mind, let us go to the lecture. So like everywhere there are mimickers, you can guess who these people are. I really like Shilpa Shetty. So there's a lot of mimickers, Anupam Kher, a lot of mimickers. I do not know who knows the last two, they are twins. Those two ladies. Anyone? Yes. And samne wala upar to sabko pata hai. I think that dimple looks too artificial, but anyway. Then you got mimickers in the universe also. Various constellations, stars, they're all mimickers and confounders. So as I said, whether it is a fly or the bee, if the sting comes, tumhe jhelna hai sting. ठीक है ना? So before it stings you, you should be absolutely a perfectionist. And your diagnosis should be with mathematical precision. So this lecture is based on so many articles which we have gone through, some of which have been written by us. For example, an aplastic anemia terminating in hairy cell leukemia. You will have these confounders. Aplastic anemia, but actually it terminates in hairy cell leukemia. Did we miss hairy cell in that aplastic anemia? So this is one confounder. Then we have read the consensus guidelines for the diagnosis and management of patients with classic hairy cell leukemia. So you have to really read a lot of literature before you actually present a case. Whether that literature emanates from your own personal experience. So something like that. So morphological confounders and a CD19 negative, imagine, CD19 negative case of hairy cell leukemia, unheard of. So this is in Mediterranean Journal of Hematology. Plasma cell leukemia masquerading as hairy cell leukemia. Look at this. You all thought it was plasma cell leukemia, it was turned out to be hairy cell leukemia. Look at the management, look at the protocols. So many confounders. Then the Walter Kluwer update articles, clinical features and diagnosis of hairy cell leukemia. So these are some interesting articles which you must read. BRAF V600E mutations, immunohistochemical analysis. So ISMO guidelines, hairy cell leukemia and its mimics, the beautiful articles in Hepatopathology, a very famous journal for the hematologist and pathologist. This is my own journal, Clinical Pathological and Ultrastructural Findings in Asian Indians. This was in Indian Journal of Cancer. Very nice article. I mean, this is all AIMS data which we diagnosed. Those were the days when IHC was there, but electron microscopy was also there. So we used to do a lot of electron microscopy in hairy cell leukemias. And of course, this is Colonel Venkat. He's also done his DM from AIMS. He's now in transfusion medicine. A decade-long experience of North Indian Hematology Center. So a lot of contribution, a lot of studies, a lot of efforts. So let us go to the case history. So the first case is a 60-year-old male who presented to the OPD with complaints of weakness and fatigability for the past 3 months. And an episode lasting a week of fever, and that he had 2 months back. So when he came to us, we asked the history, and as usual, there was no history of bleeding, bone pains, or abdominal discomfort. I do not know why he did not have abdominal discomfort, because when we examined him, he had hepatosplenomegaly. So hepatosplenomegaly may or may not come with early satiety, may or may not come with abdominal discomfort. So you have to examine the patient and then see the slides clinically. Okay? So there was no retroperitoneal lymph nodes, and these were the lab investigations where the TLC was 19,400. He had okay, hemoglobin was 12.6, platelets are okay, and lymphocytes were 89%. What do you call this condition? Absolute lymphocytosis. Vis-a-vis relative lymphocytosis, which we see in aplastic anemia and pancytopenic smears. This is absolute lymphocytosis. And what did the PS show? Large atypical cells, lymphoid cells. We calculated 14% in the PS were large atypical cells. As I told you yesterday, we do not use the word atypical cells. Write abnormal cells. What is the harm? At least abnormal cells is not normal. Atypical cell is actually technically a benign cell as per hematopathologists. But the message which you give to your clinicians, he will think atypical cell is a malignant cell. So then it is better to write, we are saying abnormal cells. These large lymphoid cells consisting 14% of the population were abnormal cell, few showed polar villi. So see the picture. You're seeing the arrows, which are beautifully depicting the polar projections of these large atypical lymphoid cells with moderate agranular amphophilic cytoplasm and a large nucleus, some with a nucleoli. And we still do not know what it is. So we did a bone marrow aspirate, and those large lymphoid cells were classically seen in the bone marrow cells. Can anyone say which is a normal lymphocyte in this? So this could be normal. We don't know. Ideally, we should not count this as any cell because it doesn't have a cytoplasm. It just looks like some particle. But yes, this looks normal. So this chromatin, whenever you see a lymphocyte having both hetero and euchromatin, which means you have multiple colors. Peripheral condensation, central clearing, peripheral condensation, central clearing. It is a surest sign of a benign cell. vis-a-vis a non-benign cell or a so-called malignant cell or atypical cell where the chromatin is opening up. So the heterochromatin, euchromatin, they are converging into one big mass of chromatin. So that's why you call it hyperchromatic, vesicular. All these features are based on your chromatin content. So always diagnose your cells by the chromatin nature. Okay. So these are these cells you're seeing, abnormal cells. And if you see the inset, this is that abnormal cell. And you can go on and describing in all ways, and all of you will correctly describe it. There's a large nucleus, and some sort of polar projections are coming out. Okay, so with this in mind, these were the differential diagnoses. Are we dealing with a splenic marginal zone lymphoma? Are we dealing with a hairy cell leukemia variant, or are we dealing with a classical hairy cell leukemia? We do a trap stain, tartrate resistant acid phosphatase, and it is weakly polar positive. Okay, but the trap stain, it has to be standardized. Majority of the labs don't do the stain. Many people say trap stain is redundant. Well, we don't agree. No stain can be redundant. If you have got a good technical technician with you, if you've got people who have actually worked in the bench, this is a very good stain actually. So if your stain is standardized, then the stain is good. 90% of people want shortcuts. So they don't do the stain. So trap stain is redundant. I disagree. So then we did the flow cytometry on the bone marrow aspirate, and we saw, for example, here, what is this? FMC7 CD10. And FMC7 47 and FMC7 positivity negates a CLA. Remember this mnemonic or this sort of word. It's not a mnemonic, it's just a phrase. FMC7 positivity negates the CLA. Okay, so this is FMC7. This cluster is FMC7 positive. So we are not dealing with CLA. So first CLPD then. Then what we see is a CD10 negative. This cell which we have gated is CD10 negative, FMC7 positive. Then they are CD200 positive and CD79B positive, which clearly says it is not mantle. A CD200 positivity negates the mantle. Have you understood? So this is how you should approach flow. FMC7 positivity negates the CLA. CD200 positivity negates the mantle. So this is a CD200 and CD79B positive. So we have removed two CLPDs. Clear? CD20 positive, so it's a B cell. Right? The same orange colored cells which have been gated, nicely positive, isn't it? That is the cell of interest. That is called gated. The cell of interest, gate. Gate matlab gate ke andar humne lekar aaya. This is the cell of interest. And these cells are 11C negative but 25 positive. 11C is a classical marker of classical hairy cell leukemia, right? Along with CD25. Here the 11C is negative, but the 25 is red cell positive. Now 103, which is classically positive in classical hairy cell leukemia, is negative. 103, this red cell has not come in this quadrant. This is the positive quadrant, this is the negative quadrant. As simple as that. This is negative. But CD19 is positive expected because it was CD20 positive also. Have you understood? Clear? Flow cannot be more simplified than what I've told you. Okay. Then the T cell markers, CD2 and CD3 are negative because it has not come in this quarter. Okay. So the T cell markers are negative, and so is CD5 and CD23. Now both CD5 and 23 negative. Had it been 5 positive, 23 negative, what would you thought of? Mantle. If it is 5 positive, 23 positive, CLL. But we have now removed both of them, CD200 se or FMC7 se nikal diya tha. But this further proves that we are on the right track. So what are we dealing with? Itna kahani bolne ke baad, what is the diagnosis? So FMC7 positive, 19, 20, 79B positive, 200 positive, 25 positive. 11C was negative, 103 was negative, 2 and 3 negative, 23 negative, 10 negative, 5 negative. This is the summary of the flow. I hope you all are understanding. ठीक है? अगर नहीं समझ में आता बोलना. So we did a bone marrow biopsy. See the biopsy. Whenever you see the biopsy, in biopsy you are seeing the pattern of involvement. So you see a pattern of involvement like this. You see a pattern of involvement like this. And you see a pattern of involvement close to the paratrabecular. So it could be paratrabecular, it could be interstitial. Interstitial means normal cells are there and the abnormal cells are pushing the normal cells to the periphery. Interstitial. Paratrabecular along the bone marrow. Then nodular. So there are various methods. So whenever you describe biopsy, start with the cellularity and then the pattern of involvement. We are not interested in the morphology of cell. That you have seen in Aspirate and Peripheral Smear. This is pattern of involvement. So after you see this one pattern, as I told you, what is this pattern? Nodular. See how beautifully we are showing nodular? Okay? So nodular involvement. Then what is this involvement? Interstitial, because we are seeing normal eosinophilic cells and in between are these cells which are abnormal cells. The normal cells are there and the abnormal cells are going inside. That is interstitial. Clear? So the differential diagnosis finally is splenic marginal zone lymphoma. Could it be a hairy cell leukemia variant? Because each and every diagnosis has got a different treatment. It is not just writing in paper. Hairy cell leukemia classical, different treatment. Hairy cell leukemia variant, different treatment. Marginal zone lymphomas, different treatment. SMZL, different treatment. We did a reticulin staining. So we saw pericellular fibrosis. Indian viable papers. Pericellular fibrosis and intercellular fibrosis. दोनों fibrosis मिलेगा. Intercellular, pericellular. Okay. So differential diagnosis on the bone marrow biopsy. It could be hairy cell leukemia, interstitial involvement. It could be SMZL nodular involvement. Okay. So we do immunohistochemistry just to show what we have done in flow and nothing new. CD20 positive, 3 negative. So ISC doesn't give you anything. The flow has given you so much. And flow has given you on that day. ISC takes time. Flow is dynamic. Millions of cells. ISC is centric. एक molecular antibody. So there are a lot of advantages and disadvantages. That we'll discuss on another rainy day. Annexin. Now this what confused us. Annexin is focally immunoreactive. Now what does that mean? You expect this to be strongly positive in classical hairy cell leukemia. You expect this to be negative in SMZL. Now here हम लोग बीच में आ गए. Focally positive. So it is confusing us, and that's why this topic of confounders. Okay? So again, the differential diagnosis after all that, same. SMZL, hairy cell leukemia variant. Are you all understanding? So far after flow, morphology, bone marrow, IHC, reticulin, those 3 diagnoses which we had done on PBS, the same 3 diagnoses is still there. So what do? There was a splenectomy done. The clinicians got fed up. Spleen cut diya. And that spleen is in our museum in RR. And Gaurav is our prosector. So we've got the spleen. To see spleen in tuberculosis, to see spleen in lymphomas, to see spleen in Hodgkin's. So that is the importance of museum. Unless you read gross, you cannot read pathology. Okay? So this is the spleen morphology. What do you see? This arrow shows nodular pattern in the white pulp. This is a white pulp disease. So hairy cell variant and hairy cell classical is out. White pulp disease, those are red pulp disease, red lakes. Here predominantly what you're getting, nodular patterns centered in the white pulp. So these cells were the marginal zone type cells, the poached egg appearance or the sun fry appearance. Okay. So they were CD20 positive and they were negative for cyclin D. Again, mantle is out. 5 negative, 23 negative, CD3 negative. And what is this pattern? This is also a red pulp infiltration. So you're getting majority white pulp, but few red pulp infiltration. So hairy cell variant and classical is generally out. Then we did electron microscopy. And we saw the polar hairy projection in our case. Unlike the circumferential hairy projection, there is a both these cases are mine in Ames. So what is the final diagnosis? Splenic marginal zone lymphoma. So the importance of diagnosing of such cases is there. Because every treatment you give is based on every word you speak, your diagnosis. Okay? The discussion, trap positivity. We normally don't get trap positivity in SMZL. We get it in classical hairy cell leukemia. Annexin 1, we normally don't get annexin 1 positive SMZL. So these are the issues in our case. Overlapping immunophenotype, 11C positive, 25 negative, 103 negative. So SMZL may overlapping हो रहा है. So this is the confounder. So that's why nothing is key. इसमें यही positive आएगा, इसमें यही negative आएगा. These laws don't happen. You will have situations of overlapping. Then your morphology tells you where you are. As your Professor HOD said, many times your ISC confuses you. But be proud of that morphology and be proud of the surgical background of that case. How is that case behaving? Based on that, okay? So this is few of the references of trap positivity. I said if you are good in your standardization, this is a good test, but then trap can be positive in almost 13 to 15% cases of SMZL, as we showed in our case. Literature says SMZL may trap negative hota hai, but we have seen now few percentage of cases trap can be positive, as was in our case. Okay, so this is, we have seen trap positivity. This is a board question. 57% cases of mantle cell trap can be positive. SMZL, as you saw, some cases can be positive. Primary mediastinal B-cell lymphoma trap can be positive. 41 cases of CLL, SLL trap can be positive. Besides the classical trap positivity of hairy cell leukemia. So besides hairy cell leukemia, these are the 4 conditions in which trap can be positive. Okay? So just don't think trap can be negative in SMZ. So this is where your experience comes. Annexin 1, you all know it is 100% sensitive and specific for hairy cell leukemia. Yet we saw focal annexin 1 positive in our case. That doesn't change it to hairy cell leukemia. It is SMZ. So you must know. So how? That's why I started the lecture by saying that we read literature. In the literature, you come to know that in certain percentage of SMZL, annexin 1 can be positive. So it is limited. We found annexin 1 as limited usefulness because many of our control cases, like normal B cells and T cells in the bone marrow, they can also take annexin 1 positively. Then to interpret a hairy cell leukemia in a bone marrow where the normal controls are taking positive is very difficult. So all these findings underscore the importance of establishing the B-cell nature of a neoplasm. So we have devised an immunophenotype score. In this immunophenotype score, we give 1 point to each of the 4 expressions. So 1 point for 11C, 1 point for 103, 1 point for 25, and 1 point for 123. Clear? So a score of 3 to 4 is observed in 98% cases of hairy cell leukemia. So by the simple scoring, hairy cell leukemia confounders or hairy cell leukemia-like disorders, the score will be much less. It will be either 0 or it will be 1 like we had in SMZL. Whereas 3 to 4 maximum score is in hairy cell leukemia. So if you can standardize these 4 markers in your CLBD panel and you do a scoring, you can get a quick diagnosis. Have you understood? Are you all awake? Only Gaurav is sleeping. Because he has heard my lecture so many times. Okay? And remember, CD25 is positive in 25% cases of SMZL. So this is splenic marginal leukemia. You can read the theory from your books. The treatment. Now, not all patients require treatment. Many of the SMZL has co-HCV infection. And that's why antiviral therapy of HCV can also cure the SMZL. Okay. Splenectomy, as I told in our case, is an acceptable alternative, particularly patients who have got localized symptoms like early satiety, discomfort in breathing. You can take out the spleen, and we give rituximab. So rituximab is one of the most important treatments in SMZL. So the moment you diagnose SMZL, you start him on rituximab, and the spleen shrinks from a massive splenomegaly. It comes. See the comfort you have given to the patient. Okay? So that's the idea. So peripheral smear and bone marrow is essential. Flow cytometry, the 4 markers are essential with coding 11C, 25, 103, and 123. If you do ISC, a 20 and a DBA 44 can help you. And a BRAF mutation of B600E in the near future. Now we know we have standardized that in ISC. Because all classical hairy cell leukemia will have a BRAF B600E mutations. So with this in mind, the second case. You all know what hairy cell leukemia. We will not go into this. We have already discussed. And why the diagnosis of hairy cell leukemia is important? Because you give curative treatment. That CLPT which is completely curative is hairy cell leukemia. So the diagnosis is so important because you are going to cure this patient of a malignancy. So hairy cell leukemia is a curative malignancy amenable to treatment by all those nucleoside analog treatments. So you got first line treatment, which if it's symptomatic, you can give cladribine and pentostatin. And believe me, this question is asked to pathology in MD, in Viva. Can you name 2 medicines which have cured this disease? So cladribine, pentostatin. This is a standard question asked in Viva. Okay. So these are the hairy cell-like disorders. The hairy cell variant, the SMZL which we have discussed in the previous case. Now the new entity, splenic, diffuse, red pulp, small B-cell lymphoma. It is called SDRPSBCL. Splenic, diffuse, red pulp, small B-cell lymphoma. Then we have the BPLL or B, pro-lymphocytic leukemia. CLL, SLL will always come, including atypical CLL. And of course, plasma cell leukemias, as I told you in the initial fact, some of the plasma cell leukemias mimic hairy cell leukemia. So those so-called wavy hairy-like projections are not necessarily hairy cells. Case 2. So 81-year-old man was evaluated for leukocytosis with 90%, again, atypical lymphocytes, and I still feel you should call it abnormal lymphocytes, with mild thrombocytopenia. The atypical lymphocytes, what we found were large and standard description, round or oval nuclei, condensed chromatin, prominent nucleolus, blue-gray cytoplasm. These are very important. So go with this description. When we did the flow of these cells, it was CD19 positive, 11C positive, 103 positive, 25 negative. What do you think it is? So we'll see what it is. This was the peripheral smear. See? So these are abnormal lymphocytes. Okay? This is a peripheral smear. We did a bone marrow. These abnormal cells were seen in the bone marrow. And if you see the inset, these were the cells, bone marrow aspirate cells. Convoluted nucleus, abundant cytoplasm, a granular, founding nucleotide, and some like projections. Okay? Again, confounders, you don't know what this is. And it was among the 4 markers, 3 were positive. Which was negative? 25 was negative. 11C positive, 103 positive, 19 positive. So 3/4 score, 3 out of 4. So SMZL out. CLL तो सोचना ही नहीं है. ठीक है? So where are we? Classical, stroke, variant. Simple. समझ में आ रहा है सबको? 60 to 70% abnormal lymphoid cells showing pleomorphism, convoluted nuclei, blue cytoplasm, prominent nucleoli. So again, are these blasts? Are these atypical lymphocyte or abnormal lymphocyte? So WHO in 2016 has said hairy cell variant has to be distinguished from 2 other B cell neoplasms which present as hairy cell leukemia. This is a WHO language. Which one? One is classical hairy cell leukemia and second is SMZL. And now you all know SMZL is out because I'm not going to show you 2 consecutive SMZL cases, obviously. I've already discussed, plus the score, 3 out of 4. So variant hairy cell leukemia. This is variant hairy cell leukemia. Entity that is biologically distinct from hairy cell with morphological features intermediate between hairy cell and pro-lymphocytes. Sometimes people say that variant is actually a family of PLL. It is more like PLL and not like hairy cell leukemia. But still, historically, we use the term hairy cell leukemia variant. The hairy cell variant has prominent nucleoli and less marrow infiltration. The hairy cell classical infiltrates the marrow, where the variant has got patchy infiltration. And there is extreme leukocytosis. These are classical questions in Viva. Extreme leukocytosis, unlike classical hairy cell leukemia, which presents with pancytopenia and with monocytopenia. Hairy cell variant never has monocytopenia. The variant, the classical, always has monocytopenia. So this is the immunophenotype. Both express 20, 22, 11C and 103. But unlike hairy cell leukemia, which has a typical bright, now whenever you use low, you use bright expression. So unlike hairy cell leukemia, which has a very bright expression of 123 and 25, the variant does not express 25. So here 25 was negative. So variant never expressed 25 and is dim or negative for 123. Unlike classical, which is brightly expressed for 123 and 25. In addition, annexin A1, if you remember, annexin A1 is expressed in 75% of cases of hairy cell leukemia classical and is universally negative in hairy cell variant. So name 3 markers in hairy cell variant which will distinguish you from classical. CD25, CD123, annexin A1. And lastly, it always lacks the BRAF mutation V600E. Board questions, 4 answer isme clear cut. Okay? So these are various other ways of differentiating variant versus hairy cell which we have discussed. And this is the treatment. Treatment again, almost the same, where we give cladribine, rituximab. But the problem is the variants respond not as well to the standard nucleoside analog treatment as does the classical. So variant has got a dismal prognosis compared to classical. Okay. Case 3, happy? Awake? So we have discussed SMZL, we have discussed variant. 52-year-old male with B symptoms. What are B symptoms? Fever, night sweats, weight loss. Has a huge spleen. One CLPD with a huge spleen. Tell me. One myeloproliferative neoplasm with a huge spleen. CML. One CLPD with a huge spleen. किसी को पता नहीं है. So we'll discuss this. Okay. Rapidly rising TLC. Currently, when we saw the patient, pallor 7.2 gram, TLC 1,20,000. Platelet low, 72% pro-lymphocyte. So PLL is that CLPD with massive splenomegaly. Okay? So this is BPLL. This is how the cells go. These cells are larger than normal lymphocytes with a characteristic nucleus. Larger lymphocytes se bhi larger with a characteristic nucleoli. So we saw numerous large lymphoid cells. Again, you see this hairy projection? Again, a confounder. Numerous large lymphoid cells in the peripheral blood. Distinct nucleoli, scant to moderate cytoplasm is the characteristic of BPL. Leukocytosis with greater than 55% and up to 90% are pro-lymphocytes. And the bone marrow infiltration is interstitial or nodular. You can have either of the 2 types of infiltration. So this is the BPLL flow cytometry, which is very bright for CD20 as well as other B cell antigens. What are they? CD19, 22. Normally cytoplasmic CD22, CD79B and FMC7. Name one CLPD which is FMC7 negative. FMC7 positivity negates a CLL. मैं उल्टा क्वेश्चन पूछ. Name one CLPD which is negative for FMC7. CLL. Most of the CLPDs are positive. So this is another way of remembering. Okay. Okay. So BPLL can be seen either as a transformation of a CLL or it can be seen as a de novo disease. You can have in 2 conditions. बोलते ना CLL, PLL. So either transformation or de novo. So blastoid transformation of mantle cell lymphoma is the closest differential diagnosis when you're talking about a BPLL. So when you're thinking of a BPLL, what comes in your mind is not hairy cell variant or SMZL or the blastoid transformation of mantle cell. So do a translocation 11-14, which in IC is cyclin D1. So फटाफट cyclin D1 को negate करो and you will think of BPLL. If it is positive, blastic phase of mantle cell lymphoma. Have you understood? Practical points. Case 4. See, such a short case. Happy? Case 4. Okay. 48-year-old male, early satiety and abdominal distension, massive spleen with gradually falling counts. Okay? Massive spleen with gradually falling counts. What could be the answer? Simple. It could be either classical hairy cell leukemia or SDR-PSBCL. That is splenic diffuse red pulp small B cell lymphoma. This is a new entity in your WHO. Rare but very good prognostically. So SDRPL versus hairy cell leukemia. There is diffuse infiltration of the bone marrow and peripheral blood and the splenic red pulp by these small monomorphous lymphocytes with villous projections. They all look like hairy cell, but they are negative. So you see hairy cells, but they are completely negative for A1, 25, 103, 123, level 6. So if you do a scoring, it will be 0. Yet it looks like hairy cell. Have you understood? So this is a new entity. Okay? And then you can see the spleen and you can dissect the spleen and find out all this condition. And in case of doubt, BRAF mutation. जैसे BRAF mutation B600E positive, classical hairy cell leukemia. बाकी सोचने का नहीं. Clear? And this is annexin A1. Again, it will be negative in SDPRL and so nicely positive in hairy cell leukemia. Is it positive in SMZL? First case, focally positive, maybe, but generally negative. Okay. Now we come to a scoring which we have devised. Colonel Venkat and I, we have devised. This has gone for international. It has been published. We have decided on a 3-point cutoff, and we do a CD 200 and a CD 180 median fluorescence intensity ratio. And this helps in distinguishing hairy cell leukemia from SDPRL with a ratio of 0.5 or less in favor of SDPRL. So this is a ratio based on fluorescence intensity. So this is recent advances. I think my penultimate case, 76-year-old woman, pallor, fatigue, body ache. Actually, all the histories are the same. CLPDs will always have this easy fatigability, myalgia, all that thing. So the complete blood count showed hemoglobin, leukocytes, lymphocytes, platelets. Again, absolute lymphocytosis. Hai? Peripheral blood smear. Can anyone describe it? Large atypical lymphoid cells, again, abnormal cells, 82%, with hairy and shredded cytoplasmic projections. Shredded, tuta hua, fragmented, hairy projections, with prominent nuclei resembling variant hairy cell. Okay? So what are we dealing with? Go back to the history. Old lady with normal counts, but pallor and thrombocytopenia. But TLC is normal, but the lymphocytes are predominant. And we saw this shredded hairy-like cells. Further investigation. Site scatter and a CD19 gated cell clutter lacked complete expression of 11C, 23, 103, 123. आपने जो CLPD panel डाला, सब खलास, सब negative आया. All your diagnosis is gone. But it expressed CD38, strong. CD138, strong. CD56 co-expression. And a lambda light chain restriction. Plasma cell dysplasia. It was actually plasma cell leukemia. Or gas which are hairy cell. So, hirsutism is something else. Give it to the endocrinologist. You are a pathologist. All cells which are hairy are not necessarily hairy. Okay. So we got a M spike, we got a IgG lambda, and the overall features were consistent with plasma cell leukemia. So look at the confounders. The plasma cell leukemia mimicking variant hairy cell, and hairy cell is well known. And this is the literature. This case highlights the rationale of plasma cell leukemia being taken as a BD when one says difficult morphology. What does that mean? That means that when you do your flow cytometry and you standardize your CLPD panel, add a 38 and a 138 also in that panel, but not in the primary panel, in the secondary directed panel in case you have some difference in leukemia and difficulty. Okay. Last case. Okay. Now concentrate. This will be interactive. Young lady. Awareness of mass. Left and right hypochondria. 2 months. Fever. Epistaxis. Liver 7 centimeter below costal margin. Spleen 20 centimeter. Big spleen and a moderate hepatomegaly. In a young lady. Young lady में CLPD आमतौर पर होता नहीं है. हम लोग सब elderly बोलते हैं कि 50 साल के ऊपर. Young lady. So it keeps you thinking कि क्या है. Lab 9.5, 13,400 TLC, lymphocyte 64. ठीक है. Lymphocyte 64, of which atypical पे 15%. ठीक है. Thrombocytopenia. You know where? है ना? तो standard है. Peripheral smear. See the cells. बोलो. Normocytic, normochromic RBCs, large atypical lymphoid cells are seen. The first thing you see in the cells are, these cells are looking too angry to be called hairy cells. Too angry मतलब too anaplastic. It's looking huge. It's looking bizarre. इतना बड़ा न्यूक्लियस hairy cell में नहीं होता. ठीक है? But huge cytoplasm. So it is looking bizarre. What is this cell? Nucleated RBCs. Don't forget that. Okay? Bone marrow aspirate. What did we see? See the bone marrow aspirate. See these large cells. They are blastoid. So suddenly you think, यार AML तो नहीं है. What the CLPD we are talking about? AML तो नहीं है. So remember, sometimes these things, undifferentiated leukemias, acute undifferentiated leukemias, mixed phenotypic acute leukemia, and something else which will come in the diagnosis can also mimic. Acute history. 26 साल की लड़की, why are you thinking of CLPD? Okay. Now, so we saw middle size to large atypical lymphocytes. हमने lymphocytes बोला because उसका उसी तरह लग रहा है chromatin. ठीक है. Pale cytoplasm, irregular nuclear contours, prominent nucleoli. NPO, हमने NPO किया. NSC किया. Negative. That doesn't rule out myeloid. It could be undifferentiated also. So, was it ALL? Was it hepatosplenic lymphoma? Was it SMZL? Was it TLGL? It is not TLGL, large granular lymphocyte. No. It comes in elderly. It is associated with rheumatic heart disease, rheumatoid arthritis, Welty's syndrome, and a lot of other things. Okay. Flow 1934 negative. Acute leukemia out, 34 negative. 519 negative. Mental out, CLL out. सोचा भी नहीं था ऐसे. 3 positive. TTG negative. T surface CD3 positive. CD3 positive, surface CD3 positive. So we are dealing with T. Again, dual negative 4-8, significant. Dual positive, dual negatives are both significant. So 4-8, dual negative. PCR, gamma delta positive. ठीक है? Alpha beta negative. The T cell receptors 4 है ना? तो gamma delta positive. Surface CD3 positive, 56 negative. So LGL is out. 64 11C negative. Monocytic markers are out. HLA-DR MPO negative. Diagnosis. So summary. बोलो. Bone marrow. Infiltrated with a monomorphic population of neoplastic lymphoid cells. ये क्या है? Sinusoids. Sinusoids के अंदर classical 2 conditions: intravascular lymphoma and the present case. 2 conditions: intrasinusoidal. Got it? CD20 negative because T markers है. 3 positive inside the sinusoids. कितना बढ़िया है? INC is very good. Immunohistochemistry staining for CD3 highlights lymphoid cells within sinusoids. Differential diagnosis. T NK cell neoplasms. Either precursor lymphoid neoplasm, that is T, ALL, CD34 negative, TDD negative, out. Mature T NK cell neoplasms. क्या होता है इसमें? Cutaneous, we are not dealing with that. Extranodal, yes. Nodal, we are not dealing. Leukemia. Leukemia, ATLL, adult T cell, leukemia lymphoma, aggressive NK cell leukemia, TPLL, TLJ. Nodal, peripheral T cell, not otherwise specified, anaplastic large cell lymphoma. Very important. And plastic T cell lymphoma. Extranodal, NK T cell, enteropathy, hepatosplenic, subcutaneous. Cutaneous में mycosis, transform mycosis, Sézary, primary cutaneous which is 30 positive, and primary cutaneous gamma delta T cell. These are what you have to think of in this case. Nako? Clear? Nako? Clear? 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 TALL versus hepatosplenic T cell lymphoma. So this is a case of hepatosplenic gamma delta lymphoma. Young age, big spleen, moderate liver, this range. So TLL, acid phosphatase positive. Here, gamma delta, TLC is increased in thousands. This is in lakhs, TLC, this is in thousands. And these are the types of chromatid you see. But main thing is CD3 positive, 56 plus another PCR, gamma delta will be positive. So you have to think about this situation. Okay, so with this, we come to the diagnosis of hepatosplenic T cell lymphoma. So this, in essence, is in short the confounders of hairy cell leukemia. Okay. To summarize, morphological differences you have discussed, immunophenotypic differences we have discussed, the scoring we have discussed, the genetic aberrations like BRAF mutations we have discussed. And this is the summary. I just need the main ideas. Baki mere upar choro. I forgot to add Colonel Gaurav's name. Acknowledgement. So another brilliant boy, Colonel Ankur Ahoja. Hopefully next year I will introduce him. Colonel Venkatesan is my junior colleague. He's a TM in hematopathology. KJ Singh is a molecular pathologist, all from Army of Lara, where we fine-tuned all our cases. Thank you so much.
I am very sure that everyone must have enjoyed, and what a beautiful way sir has made everything complex, difficult, and our fearful hematology simple. So again, a big hand to sir. Sir, thank you so much.